Okay, your cholinergic or cholineceptor activating drugs. Cholinesterase inhibiting drugs. Cholinesterase is the enzyme which metabolizes your acetylcholine. Okay? And then your cholineceptor blockers. Okay, your cholineceptor activating drugs. Okay, remember your acetylcholine. This is the neurotransmitter in the cholinergic system. Okay, so this is the chemical structure. So they are being synthesized from your acetyl-CoA and your choline. Okay. So they are the endogenous neurotransmitters. They have no therapeutic application, but they have diffuse action. Okay? So when this acetylcholine act on our cholinergic receptors, action is almost from head to toe again, just like your adrenergic system. And they are rapidly hydrolyzed by this enzyme, okay? Acetylcholinesterase in the ganglion and in the synapses, in the neuromuscular endings and in the synapses, and then in the plasma, they are hydrolyzed by this enzyme. They are plasma butyryl cholinesterase. But the one that is being metabolized by this is not actually your acetylcholine, but the choline esters, which will be the raw material for the synthesis of the acetylcholine. So if choline is already hydrolyzed, then it will affect acetylcholine synthesis because there is no raw material for its synthesis. Okay, just like your adrenergics, we have your direct acting. Okay, your direct acting agonists and the indirect agonists. Okay? So in direct acting agonists, if they act directly on your cholinergic receptors. While your indirect ones will be what? Those that will affect its synthesis and its metabolism. Okay? So these are your muscarinic receptor agonists. You have your choline esters and the naturally occurring alkaloids. Okay, muscarine is from mushroom, okay, from poisonous mushrooms, and this is selective for your muscarinic receptors. Then your pilocarpine from the Pilocarpus plant. And this is not a substrate for cholinesterase. Okay, so this is not metabolized by cholinesterase. It is, again, selective for muscarinic receptors. And then your arecolin from betelnut, okay, also not a substrate for cholinesterase. And it is also selective for your muscarinic receptor. Okay, so this is your muscarine. This is an alkaloid from mushroom, Amanita muscaria, and it has only muscarinic actions. Okay, it has no clinical use, but it can cause poisoning due to ingestion of the poisonous mushroom. Okay, you have your early onset mushroom poisoning and late onset. For the late onset mushroom poisoning, this is the one which has neurogenic symptoms. Okay, early onset, this will occur about 30 minutes to 1 hour after ingestion of the mushroom. Okay, the muscaria can cause mild cholinergic symptoms, and your inoside or glycoside will have severe cholinergic symptoms. So this is the species of mushroom. And then for the late onset, this will occur within 6 to 15 hours of mushroom ingestion. This is your Amanita phyloides, and these are the signs and symptoms of late poisoning, referring to the CNS. Okay? Neurogenic signs and symptoms. Okay, pilocarpine from the plant Pilocarpus. So, in the early days when they chew the leaves of this plant, they have salivation. Okay, because they're cholinergic, part of that will be increased secretions of the glands, including your salivary gland. And then first experiments was on this plant was done in 1874 by a Brazilian physician Fodenco. And then this was isolated in 1875, and these are the actions that they have found out. It will affect the pupil, so the pupil will it will constrict parasympathetic vestibular constriction, increase secretions of the sweat glands and the salivary glands. Okay, these drugs, the muscarinic agonists, they bind with high affinity and they activate the muscarinic receptors. So they mimic the effects of the endogenously released acetylcholine by the parasympathetic nervous system. So which have effects on the eyes, the lungs, the heart, the gastrointestinal tract, as well as the genitourinary tract. Okay? And then specificity for muscarinic or versus the nicotinic receptors will vary, as well as the inactivation by the enzyme cholinesterase. Okay, so these are the different organ system effects. Remember, your parasympathetic or cholinergic is craniosacral. Okay? Cranial nerves and the sacral nerves. Okay, so on the pupils, constriction. Okay, on the glands, your salivary glands increase secretion, produce watery secretion. On the lungs, bronchoconstriction. On the heart, okay, decreased heart rate as well as the contraction velocity. And the stomach, increased motility and secretions. Liver not innervated by your cranial nerve. Pancreas, there is increased secretion of the digestive enzymes and enhances insulin release. So practically for the GI tract, it is increased. Okay? Increased motility, increased secretions. Kidney not innervated by the cranial nerve. Now in the small intestine, there is also increased motility and secretions. Now take a look at the big colon, okay, your colon, big intestine, large intestine, okay. Proximal part, it is innervated by the cranial nerve, okay, particularly your 10 radius nerve. And then the distal part of the colon and the rectum is innervated by the sacral nerve. But the effect is the same, no? Increased motility also. And then in the bladder, okay, there is increase in the detrusor muscle tone. Okay. So in the eyes, okay, both the iris muscle and the ciliary muscles are being affected. Both of them will contract, producing meiosis and accommodation. Okay. So, this is what is happening. The peripheral iris is being pulled away from your trabecular network, and then there is constriction of the pupillary sphincter muscle. This is your circular muscle of the eye. So, if this will contract or constrict, then the pupillary opening will decrease. So, you have your meiosis. Okay, now we go to the lungs. Okay, the receptors here, muscarinic 3 receptors, okay, will affect the glands and the smooth muscles. So there will be glandular secretion, okay, and then contraction of the visceral smooth muscle. Okay. Now the The smooth muscles in the viscera is mainly vascular, and this results from your matrix muscle. Okay, now here in the lungs, there will be bronchoconstriction and increased mucus discharge. On the heart, there is stimulation of the cardiac muscarinic receptors, resulting to bradycardia, negative inotropic effect, and the reduction in the AV nodal conduction. This is where your mass coverage. And then, there could be vasodilatation in the vascular endothelial cells. Okay? Due to the release of your matrix muscle. So, in total, there will be a reduction in peripheral vascular resistance and a change in heart rate. So, if there is decrease in peripheral vascular resistance, what will happen to the blood pressure? It will go down, okay? And then there is also a change in heart rate. There is slowing down of the heart rate. Okay, on the GI tract, okay? Increased motility secretion, stomach, pancreas, increased secretion. So this will happen. Mainly excitatory effect, glandular secretion, stimulation, the salivary, bronchial, and sweat glands, as well again as the contraction of the visceral smooth muscles. So there is increased motility along the GI tract. Okay, on the bladder, contraction of the deductor muscle and relaxation of the trigone and sphincter muscle, so it promotes voiding. For adrenergic, it is actually the opposite. Okay? The deductor muscle relax, the trigone muscle and sphincter muscle contract, so you have urinary retention. That is for your adrenergic. So practically, if you know the adrenergic, then you will know the cholinergic effects, because they are just the opposite of each other. Okay, so your nicotinic receptors and your muscarinic receptors. Okay? So your nicotinic acetylcholine receptors are found in the post-synaptic membrane of all autonomic ganglia and all neuromuscular junctions. Okay? And some in the CNS pathways. While your muscarinic acetylcholine receptors, okay, so when these are activated, you produce the parasympathetic nerve effects in the heart, smooth muscles, and the glands. And your muscarinic acetylcholine receptors are G protein coupled receptors. Okay? So this is the G protein. Okay? And then this is your ion channels, ligand-gated ion channels for your nicotinic acetylcholine receptors. Okay. So during depolarization, sodium comes in, potassium goes out. So there will be excitation of the receptor. Now here, this occurs during hyperpolarization, wherein the potassium channels are open, and then your potassium channels go out. If the membrane is hyperpolarized, okay, it will not be stimulated to depolarize. Okay? So that's why you have inhibition. So there is production of slower heart rate. Now, during this time, okay, if there is another depolarization here, remember if the potassium channels are closed, your potassium cannot go out. Okay? So there is now excitation causing smooth muscles of the digestive tract to contract. Now we come to your cholinesterase inhibiting drug. Okay, remember this? This is the synthesis of your acetylcholine from choline and acetyl-CoA through the action of choline acetyl transfer. Okay, you form an acetylcholine. And then when there is what? When depolarization comes, action potential, okay, then there will be influx of calcium, and this will bring about the movement of these vesicles, fusion with the membrane, and then rupture and exocytosis. So your acetylcholine is now in the synapse, okay, or in the skeletal muscle junction. So they are now going to act with your muscarinic receptors and your nicotinic receptors. But there is another structure here, another character in this plate. Say your acetylcholinesterase, the enzyme responsible for metabolism of acetylcholine. So they are being metabolized or broken down into choline and acetate. Now choline will be uptaken into the membrane, okay, to be what? Recycled for the formation of another molecule of your acetylcholine. Okay, so that is what is happening in the cholinergic neurotransmission. Okay, your cholinesterase inhibitors, they are indirect active cholinomimetics. Okay, so remember the synthesis of your acetylcholine. The enzymes are here. Okay, so you break down the acetylcholine into choline and acetic acid. Okay, now if you give an enzyme inhibitor, your cholinesterase inhibitors or your anti-cholinesterase enzymes, then this will inhibit these enzymes. Okay? So acetylcholine will not be broken down into choline and acetic acid. So your acetylcholine will stay longer in the synapse and in the entrails to take this effect to continue your cholinergic neurotransmission. Okay? Okay, your acetylcholinesterase, which is localized in the junctions and in the synapses, okay, neuromuscular junctions. And this is primarily responsible for inactivation of the released acetylcholine. Okay, the one that is being released into the synapse and in the junction. While your cholinesterase, this is found in plasma and on platelets. And the substrate for this enzyme is not acetylcholine actually, but the raw material for the synthesis of acetylcholine, which is your choline esterase. So if the raw material is being decreased or metabolized by this enzyme, there will be no formation of your acetylcholine. Okay, because you leave it. So, what will happen? No synthesis of your acetylcholine. That's why you need to block or inhibit these enzymes to have more of your acetylcholine. Okay, so this is what your cholinesterase inhibitors will be doing. They will prolong the acetylcholine's effects on the muscarinic sites, on the neuromuscular nicotinic sites, and autonomic ganglia. Okay? Look at this. Physiologically, this is what is happening. You have the enzyme to metabolize your acetylcholine. So, what would be? Okay, few acetylcholine will be left to act on the receptors to produce the response on the smooth muscles, cardiac muscles, skeletal muscles, and the different glands. But in the presence of cholinesterase inhibitor, remember the enzyme will be blocked. So acetylcholine will not be metabolized. So you have more acetylcholine to act on the receptors and produce the cholinergic response. Okay, your cholinesterase inhibitors, you have your two groups, your reversible anti-cholinesterases and the irreversible anti-cholinesterases. So these are your reversible ones. The naturally occurring is your fascistigmine. And then the synthetic ones are your, this one, led by your neostigmine. Okay? Then the irreversible anti-cholinesterases, you have your organophosphate compound. Okay? This is found in insecticides and pesticides. That's why your organophosphate glycerine is commonly seen in patients. Their history will always reveal that they were on the farm when the accident happened, right? Or the incident happened. And then they are also found in nerve gases which are being used in the war. So these are your tabun, sarin, and stomach. Okay? And then the carbamates which are present or ingredients in our insecticides, particularly Bible. Don't worry, I have no financial relationship with this company. What I am doing now, only Ama is paying me, not the company. Okay, there is no conflict of interest. Because you should know that what Bible contains. Okay? So these are the chemical groups. Okay, your hydrochlorium, this is a simple alcohol with a quaternary ammonium group. Okay? For carbonates, like your neostigmine, these are carbonic esters with quaternary or tertiary ammonium group. And then your organophosphates, like your ethylphosphate, they are organic derivatives of phosphoric acid. That's why organophosphates. Okay. Now, do you know the difference between quaternary or tertiary ammonium group? The main difference between tertiary and quaternary amine groups is their ability to pass or traverse the blood-brain barrier. The question now is which one will traverse the blood-brain barrier so that there will be CNS effects? Tertiary or amine? Huh? Your tertiary is the one that is able to traverse the blood-brain barrier. Okay. So, according to the duration of action, there are those with short duration of action, intermediate duration of action, and long duration of action, or the irreversible one. Okay? So, short duration of action, it is your hydrochlorium, about 5 to 15 minutes. Intermediate duration of action, you have your neostigmine, fascistigmine, pyridostigmine, ampicmonium, and tertiary. While those with long duration of action, irreversible, you have your isofluorophate, ethylphosphate, and the organic pesticides, remember? And the nerve gases. Okay, radidoxine is a drug that can reactivate the enzyme. So this is an enzyme reactivator. Cholinesterase reactivator, your radidoxine. So this is also one of the pharmacologic armamentarium in the management of organophosphate poison. Okay? Beware of the poison gas. This is, what is the poison gas? Your sarin. Sarin. Okay. Quaternary carbonates. Okay, so there is poor absorption. Okay, and in the conjunctiva, skin, and the lungs. Okay? So remember, they do not pass or traverse the blood-brain barrier. So the CNS distribution is negligible. Okay? They are relatively stable in aqueous solution, and they are metabolized by non-specific esterases and cholinergic. Okay? And the duration of effect will depend on the duration of this inhibitor enzyme complex being bound together. Okay? And then the synthetic quaternary ammonium agents, these are your endoponium, neostigmine, and pyridostigmine, the common ones. Okay, your physostigmine is known also as your acid. So this is an alkaloid which has been isolated from the calabar-bean. Okay? And in West Africa, it is referred to as ordeal poison. Okay? So these are the persons who made studies on your physostigmine. Okay. Organophosphates, okay, and several encapsulates. Okay? These are well absorbed in the skin, lungs, in the genitourinary tract, and in the conjunctiva. And they are highly effective as your insecticides. They are less stable in water than their carbonates, and it has a limited half-life in the environment. Okay, your insecticides, thiophosphate insecticides, these are your parathion, malathion, okay, they are lipid soluble and they are well absorbed by all the routes. And then inside the body, they are being converted to oxygen analog. Your malathion rapidly metabolized in birds and mammals, but not in insects. Okay? The fish also cannot detoxify your malathion. Okay, parathion, this is not effectively detoxified in vertebrates. And who are the vertebrates? Mammals, including? Okay. So these are the pharmacological effects, okay, parasympathetic. And this results from the increase of acetylcholine concentration in the junctions and in the synapses. So you have the muscarinic effects, okay, on the eyes, heart, on the GUT or genitourinary tract, bladder, and also the lungs. So these organs, okay? And then ganglionic effects, this can cause hypertension, and skeletal muscle effects, okay, facilitation of voluntary contraction and tremors. So this is just a summary and a comparison between your comparison between your physostigmine and physostigmine. Okay? According to their source, chemistry, whether they are orally absorbed, whether there are CNS effects, and then the penetration in the eye, the effects, uses, the dosing, and the duration of action. If you want, you can take a shot of this. And we're recording it. So therapeutic uses, okay? So they are used in the treatment of myasthenia gravis. Okay? Glaucoma. Bladder atony, because remember it will produce urine flow. Alzheimer's disease, and for your belladonna poison or atropine poison. Okay? So you give your cholinergic agonist there. Now, toxicity, you think the toxic potential of your cholinesterase stimulants will vary depending on how they are being absorbed, whether less or well absorbed, whether they can access the CNS, and depending on the metabolism. Okay, so the direct-acting muscarinic stimulants, pilocarpine and choline esters, toxicity of this, okay, these are the signs and symptoms of toxicity. Approximately, the pharmacological effects of the drugs. Okay, direct-acting nicotinic toxicity can be acute and chronic. Okay? So this is the fatal dose of nicotine, 40 milligrams, and this is about 1 drop of pure nicotine liquid. So it can cause CNS stimulation, skeletal muscle and plate depolarization leading to respiratory paralysis, okay, hypertension and cardiac arrhythmias, and the treatment of acute toxicity for nicotine would be symptomatic. And then chronic toxicity of nicotine is nothing else but nicotine addiction. Okay. This 40 milligrams is actually the amount of nicotine in 2 sticks of regular cigarettes. But what is the reason why it's not fatal is because your nicotine is destroyed by burning. Okay? And escapes via the side stream smoke. Let's go further. Okay, so toxicity of your cholinesterase inhibitors. Remember, the major source of your cholinesterase inhibitors are the insecticides. So treatment for these are your organophosphates, right? Organophosphate inhibitor, rather poisoning, okay? Maintenance of vital signs. Okay? The contamination, because it can be absorbed through the skin. So you strip them off of their clothes and you bathe them using alkaline soap. Then you give your antidote, your atropine, and if ralidoxime is available, you can give this to reactivate the acetylcholinesterase enzyme. Okay, now we go to your cholinergic receptor antagonist. Okay? So they block the cholineceptors. Okay, they antagonize the muscarinic receptors, and they are parasympathoglytic. Okay? Parasympathoglytic is almost synonymous with sympathomimetic, okay, and opposite also. So your cholineceptor blockers, okay, there is another number of the plant symptoms, okay, the Gibson whip, it can produce the substance. And then these are your cholinergic blockers. You have your anti-muscarinic drugs and the anti-nicotinic drugs. And your anti-nicotinic drugs is divided into your ganglion blockers and neuromuscular junction blockers. Okay? So you have 2 categories of classification. They are being classified according to their chemical structure and their therapeutic indication. Okay, again, this is the classical chemical classifications, the naturally occurring ones are your atropine and your myosin, and the synthetic and semi-synthetic ones are either tertiary amines or quaternary amines. That is the chemical classification. Tertiary or quaternary. Okay? So these are the tertiary amines. Okay, the long list of tertiary amines and the quaternary amines. So this will be able to traverse the blood-brain barrier to produce CNS effects. Okay, on therapeutic classification, okay? Okay. Tertiary amines with peripheral applications. Okay, so they can be used for PUD, peptic ulcer disease, hypermotility, and asthmatics and cytopenias. So tertiary amines switch up on the peripheral, okay, periphery or peripheral application. So this in the GI tract and then in the eyes. Okay. Quaternary amines with gastrointestinal application. Okay. In PUD, also in hypermotility, your propancillin and glycopyrrolate. Okay. The quaternary amines, which can be used in asthma, your ipratropium and your benzodiazepine. And then those which are being used for urinary disorders, oxybutyn, your trospium, the difenasin, and your tolterodine. Okay, now we go to your belladonna. Belladonna is the source of your anti-cholinergic, atropine, and scopolamine. Okay, so what are these drugs? These are muscarinic receptor antagonists. Okay? So in the olden times, in the Roman Empire, it can cause an obscure poisoning. They do not know. Okay? And then this is your atripus and your lineage, sources of your muscarinic receptor antagonists. Then in India, this was used, the roots and leaves of these plants have been used in the treatment of asthma in the olden times. Then these are the questions to study on belladonna. Okay, so chemistry, there are alkaloids and racemic mixtures, tertiary amine. Okay, there are tertiary amine. So L isomers are 100 times more potent than the D isomers. Structure of atropine, they are organic esters of cholic acid and propene. Okay? So how do they act? They are competitive antagonists of muscarinic receptors. So these are the different effects. Blockade of the parasympathetic signals, blockade of the sympathetic signals being mediated by the muscarinic receptors. Okay, pharmacological actions will affect these organs and structures. CNS, eyes, cardiovascular system, the GI tract, genitourinary tract, respiratory system, and the sweat glands. Okay? So, the next slide is on the different anti-muscarinic drugs being used in ophthalmology. So, they are using anti-muscarinic drugs to dilate the pupil because they need to dilate the pupil during some examinations of the eye. Okay? Especially if they want to see the inner part of the eye or your retina. So these are the duration of effect in case of the different anti-muscarinic drugs being used as dilators. So they are also referred to by ophthalmologists as mydriatics. Okay? Mydriatics. And this is the usual concentration that are being used. Okay, so the antidote effects is dose dependent. Okay, or dose related. So at lower doses, 0.5 milligrams, this is the effects. There are the effects like cardiac slowing, some dryness of the mouth, and inhibition of sweating. Okay, at 1 milligram, there is definite dryness of the mouth, acceleration of the heart, and mild dilatation of pupils. And at 2 milligrams, there is rapid heart rate palpitation, dryness of the mouth, dilated pupils, and some blurring of near vision. Okay? And then at 5 milligrams, they already have difficulty in speaking and swallowing. Your mask. Not looking at me. Okay, there is headache, dry and hot skin, and also difficulty in micturition and reduction in intestinal paralysis. So at higher dose, 10 milligrams, pulses become rapid and quick. Okay? The iris is obliterated, so the vision is very, very blurred. Okay? Blurred vision. Skin is flushed, hot, dry, and scarlet. Okay? There is ataxia, restlessness, and excitement, hallucinations, and delirium and coma. So these are the CNS effects because your attribute is a tertiary. Okay? So in summary, remember, autonomic receptors, cholinergic, adrenergic, we are done with this. So this is what we have today. Okay, nicotinic and muscarinic receptors. Your nicotinic divided into your ganglionic nicotinic receptors, NM, and the skeletal muscle nicotinic receptors, NM. Okay? And then your muscarinic receptors, 1 to 5. Okay? Summary again, cholinergic agonists divided into direct acting and indirect acting. The indirect acting ones are divided into reversible and irreversible. And remember that radidoxine can cause reactivation of acetylcholinesterase. Okay? So these are the 6 categories of your cholinergic drugs. Muscarinic, ganglionic, muscular, okay? Muscarinic agonist, muscarinic antagonist. Ganglionic stimulants, ganglionic blockers. Then your neuromuscular blockers, and then your cholinesterase inhibitors. And these are the representative drugs of each category. Okay? Summary of the cholinergic drugs and the receptors. Okay, so these are the receptors. Okay, where they are located, and then the effects when they are activated. What are the receptor agonists? So these are now the drugs, and what are the receptor antagonists? Okay, there is a slide here which gives you tips to understand the cholinergic drug. First is you should know what receptor the drug will affect. Okay? Muscarinic, nicotinic, okay? Skeletal nicotinic, or ganglionic nicotinic. Okay? Then you should know what is the normal response when these different receptors are being activated. Okay? And then you should know whether the drug will increase or decrease receptor activation, or whether the drug will block the receptor or activate the receptor. And that is the end of our lecture. Okay.